There's something I've been carrying with me for a long time, a kind of professional discomfort that grows a little heavier every year I spend in clinical medicine. And I know the moment I say what I'm about to say, some of my peers are going to raise their eyebrows. But after more than 2 decades of watching what happens to real patients, real people, when they follow every single medical recommendation handed to them, I can't stay quiet anymore. I'm Dr. Ming Chen, and here's the truth that medicine doesn't like to say out loud. For people over 60 or 65, sometimes the most dangerous thing you can do for your health is get too many tests. Now, I already know what's going through your head. Isn't that the opposite of what doctors are supposed to say? Aren't we supposed to catch things early? Isn't prevention the whole point of modern medicine? Yes, that's exactly what we've all been told. Screen for everything. Find it before it finds you. Stay one step ahead. That message is everywhere. In TV commercials, in waiting room pamphlets, in your annual checkup reminders. But here's what that message consistently leaves out. The story of what happens after you find something. Because once you find something, anything at all, even something that would never ever harm you, a machine starts moving. And that machine doesn't always stop in a place that's good for you. So today I'm going to walk you through 4 medical tests that I see creating more problems than they solve, particularly for people in their 60s, 70s, and beyond. And I want to be absolutely clear. I'm not telling you to avoid doctors. I'm not telling you to ignore your health. I'm asking you to become a more informed patient. Because the more you understand before you say yes to a test, the better the decisions you're going to make. But before we get to those 4 tests, I need to explain something that fundamentally changed the way I practice medicine. It's a concept called the cascade effect. Once you understand it, you'll see it everywhere in healthcare, and you'll never look at a screening test the same way again. Here's how it works. Imagine you drop a single pebble into a still pond. That pebble doesn't just sink, it sends ring outward, each one wider than the last, touching the whole surface of the water. The cascade in medicine works the same way. It starts with one test, and it ripples outward into a series of procedures, specialists, and complications, each one triggered by the last. Let me show you what I mean. You're 68 years old. You feel completely fine. You're sleeping well, exercising, enjoying your life. You go in for what seems like a simple preventive test. The results come back, and there's something there. A small shadow, a tiny spot, a number slightly outside the normal range. The radiologist writes in the report, recommend follow-up imaging in 3 to 6 months. And just like that, everything changes. That finding might be completely harmless. It might have been sitting quietly in your body for 20 years and would happily sit there for 20 more without ever causing a single symptom. But here's the problem. The moment it appears on a report, your doctor has to act. Because what if they don't? What if that shadow is something serious and they ignored it? So they send you to a specialist. The specialist orders a more detailed test. That test shows the same ambiguous finding. Now they're talking about a biopsy. The biopsy carries its own risks: anesthesia, infection, bleeding, weeks of waiting, months of anxiety. You lose sleep, your family worries, and at the end of all of it, 9 times out of 10, you find out it was nothing. It was never going to hurt you, but you've already been hurt. Not by a disease, by the cascade that started with a single test you didn't need. That's the pattern I want you to recognize today. So let's get into the first test. The first test that I see triggering this cascade over and over again, and this one is especially tricky because it's been brilliantly marketed as the gold standard of prevention, is the whole body scan. Full body MRIs and CT scans that promise to survey every corner of your internal landscape in one sitting. You've seen the ads. Come in. We'll check everything, head to toe. Catch problems before they become crises. The pitch is irresistible. Who wouldn't want a complete internal inspection? It sounds like getting a maintenance check on a complex piece of machinery before something breaks down. But here's what that inspection actually finds when you're 65 or 70 years old with a perfectly healthy body. Consider someone like a 67-year-old retired school principal. Let's call her Patricia. Active, sharp, walking 4 miles a day. No symptoms of anything. She decides to get a full body scan just to feel reassured. A few days after the scan, she's reading her report and sees it. A 4 mm nodule in her right lung. A small cyst near the kidney. The recommendation? Follow-up imaging in 3 months. Patricia, who walked in feeling healthy, walks out feeling like a patient. Every cough makes her think about that lung nodule. Every twinge in her back reminds her of that cyst. 3 months of hypervigilance. When she returns for the follow-up scan, the nodule is still there. Maybe marginally larger, hard to say. Specialist referral. Procedure recommendation. Biopsy. All of this for a woman who was perfectly fine and remained perfectly fine. The biopsy found nothing concerning. But the 6 months between that first scan and that result cost her something she can't get back. The simple, quiet experience of feeling healthy. Here's the research that should be part of every whole body scan advertisement. When you scan a healthy population of people over 60, you find incidental abnormalities, that's the medical term, incidentalomas, in somewhere between 90 and 95% of people, not a minority, nearly everyone. These are spots and cysts and shadows that are simply part of having a body that has been operating for 6 or 7 decades. They're like the small dents and scratches on a car with 200,000 miles on it, evidence of a life fully lived, not signs of imminent failure. The problem is that medicine cannot find something and then simply decide to ignore it. The moment it appears in a report, the cascade begins, and the research on outcomes is sobering. Studies following people who received whole body scans showed no reduction in mortality compared to people who didn't get scanned. They didn't catch life-threatening diseases earlier, they didn't live longer, but they did have significantly higher rates of anxiety, depression, and unnecessary invasive procedures. The scan didn't protect their health. In many cases, it actively undermined it. So what should you do instead? Here's what I tell my own patients. Stop asking what your insides look like and start measuring what your body can actually do. Can you climb 2 flights of stairs without stopping? Can you rise from the floor without using your hands or the furniture? Can you stand on 1 foot for 10 seconds with your eyes closed? These functional benchmarks tell us far more about your true health trajectory than any image. They predict falls, hospitalizations, and longevity better than most scans ever could. Instead of spending money on a full body scan, invest that time in a thorough conversation with a physician who will sit with you long enough to review every medication you're currently taking. Because I can tell you from experience that in patients over 65, there is almost always at least one medication causing more harm than benefit. Talk about your diet, your activity level, how well you're sleeping, how connected you feel to the people around you. Those factors, the unglamorous everyday ones, are the real architecture of your health. The scan is hunting for structural problems that probably don't exist. The functional assessment is strengthening the systems you already have. Now let's move to the second test, and this one touches something deep because it connects to one of the most profound fears we carry as we grow older. I'm talking about brain MRIs ordered for mild ordinary forgetfulness. Here's the scenario I see play out constantly. A 74-year-old retired engineer, let's call him Robert, occasionally can't immediately recall the name of a film he loved, or sometimes goes to the kitchen and momentarily forgets what he came for. Completely ordinary. The kind of thing that happens to virtually everyone as they age. But Robert's adult children have been reading about Alzheimer's. They're frightened. They urge him to get a brain scan just to be sure. And I understand that impulse completely. The fear of watching someone you love disappear into dementia is one of the rawest fears a family can face. But here's what Robert's family doesn't know yet and what I need you to understand. Ordering a brain MRI for normal age-related forgetfulness almost never helps, and it very often causes significant harm. Because here's what happens when Robert gets that MRI. A few days later, he's sitting in the office reading a report full of phrases like mild cerebral atrophy, age-related white matter changes, and small vessel disease. These words sound alarming. They sound like the beginning of a serious diagnosis. They sound like his brain is deteriorating. But those findings are entirely normal for a 74-year-old brain. Every single one of them. They describe what virtually every brain at that age looks like under imaging. It's equivalent to scanning someone's knee at 74 and writing in the report evidence of cartilage wear and joint space narrowing. Of course there is. That's what knees look like after 7 decades of walking, running, and climbing stairs. It's not disease. It's time. The trouble is that the medical terminology doesn't feel normal. It feels like a verdict. And Robert, who walked in with perfectly intact cognition, walks out believing something is wrong with his brain. That belief itself becomes a source of harm. Studies have shown that when you scan neurologically healthy adults over 75, more than 90% will have findings that read as abnormal on a radiology report. More than 90%. But the overwhelming majority of those individuals have completely preserved memory and cognitive function. I've sat across from patients who were managing their investment portfolios, writing their memoirs, and winning at competitive bridge, and their MRI reports looked on paper like something concerning. I've also seen patients in early cognitive decline whose brain images look relatively clean. The picture and the person are two different things. We cannot read the quality of a mind from a photograph of it. So what should you actually do if you or someone you love is concerned about memory? There are validated cognitive assessment tools we can administer right in the office in under 15 minutes. We ask you to recall a short list of words after a delay, draw an analog clock set to a specific time, complete a series of simple reasoning tasks. These tasks directly measure how your memory and thinking are actually performing, not how your brain happens to look under a magnet. And if those tests reveal a genuine concern, here is something critically important to know. The majority of reversible causes of cognitive impairment in older adults are identifiable and treatable. Certain classes of medications, particularly anticholinergics, sedatives, and polypharmacy combinations, are frequent culprits. Low vitamin B12 is extremely common and profoundly correctable. Undetected depression mimics cognitive decline so convincingly that it's frequently misdiagnosed as early dementia. Sleep apnea, which silently cuts oxygen to the brain hundreds of times a night, can devastate memory and concentration. Thyroid disorders, chronic dehydration, and urinary tract infections in older women can all present as apparent cognitive decline. We look for all of these first, systematically and carefully. And you would be astonished how often correcting one of them brings a person's memory and sharpness right back. The MRI has its place when someone is progressively deteriorating, when they're getting lost in familiar neighborhoods, when they can no longer manage medication schedules or financial decisions. Then yes, imaging is part of a comprehensive evaluation. But for the ordinary memory lapses that accompany a healthy aging brain, a scan creates confusion and fear where none needed to exist. All right. The third test. And this one surprises people because on the surface it seems completely sensible. I'm talking about routine treadmill stress tests ordered simply because someone has reached a certain age. Picture this. A 73-year-old woman, let's call her Gloria, is scheduled for an elective hip replacement. She plays doubles tennis twice a week, walks the dog every morning, and has never experienced chest pain or breathlessness during any of it. But the hospital protocol requires a cardiac stress test for all surgical patients over 70. So onto the treadmill she goes. Now pause here and ask the most obvious question. If Gloria is playing tennis twice a week without any symptoms, what is the treadmill going to reveal that her actual life hasn't already demonstrated? Her daily activities are her stress test, and she's been passing it consistently for years. But protocol moves forward regardless. And here's the clinical reality that needs to be talked about openly. Stress tests in older adults carry a substantially elevated rate of false positives. That means the test flags a problem that isn't actually there. Why? Because cardiac electrical patterns change with age, because common medications alter heart rate response, because the interpretation thresholds were largely derived from younger populations. The result is that an older patient with a completely healthy heart can produce a stress test that looks abnormal. When Gloria's test comes back with an equivocal finding, the hospital machinery shifts into a higher gear. She's referred for cardiac catheterization, a procedure in which a catheter is threaded through the femoral artery up into the coronary vessels of the heart. It's invasive. There is real risk of bleeding, vascular injury, and arrhythmia. And when the cardiologists complete the procedure, they find what you'd expect to find in a 73-year-old heart: some degree of atherosclerotic change, some modest luminal narrowing, but nothing that constitutes a surgical emergency, nothing that explains a heart attack waiting to happen. But now Gloria carries a new identity. She is, in the medical record and in her own mind, a cardiac patient. New medications appear on her prescription list. Her family starts worrying every time she exerts herself. She stops playing tennis, not because her cardiologist told her to, but because she's afraid. The procedure that was designed to clear her for surgery has instead sidelined her from the physical activity that was keeping her heart strong in the first place. Here is the practical alternative I recommend for assessing cardiovascular risk before elective procedures. Listen to what the patient's body is already reporting. Functional capacity: the ability to climb stairs, walk briskly, carry groceries, engage in sustained physical activity without chest discomfort or abnormal breathlessness, is one of the most validated predictors of perioperative cardiac risk we have. If someone is functionally active with no symptoms, that is powerful, real-world evidence of cardiac reserve. For individuals who genuinely want a quantitative picture of their cardiovascular future, there is an excellent tool, the coronary artery calcium score. A 5-minute CT scan with minimal radiation exposure produces a single number that reflects the actual calcified plaque burden in your coronary arteries. A score of 0 indicates very low heart attack risk over the following decade. An elevated score indicates meaningful risk that warrants aggressive lifestyle modification and, in discussion with your physician, possible medication. Crucially, the calcium score provides actionable information that guides prevention. It doesn't automatically launch an invasive procedural cascade. It gives you knowledge, and knowledge is something you can use. Don't let your age alone be the justification for a procedure that your daily life is already telling you isn't necessary. And now the fourth test. I want to be especially careful about how I frame this one, because the nuance matters a great deal. I'm talking about routine screening colonoscopies after age 75, specifically in individuals with previously normal colonoscopy results and no elevated risk factors. Let me be absolutely explicit. Colonoscopies are one of the most valuable cancer prevention tools in medicine. I recommend them enthusiastically beginning at age 45 or 50 in average risk individuals. They work by identifying and removing precancerous polyps before they have the chance to become cancer. If you're in your 50s or 60s and you're due for one, please schedule it. I mean that without reservation. But here is the fundamental principle of clinical medicine that applies to every single test and every single intervention. The risk-benefit calculation is not static. It changes with age, with overall health, and with life expectancy. And for colonoscopy after 75, this recalculation is something that needs to happen honestly and openly between patients and their physicians. The benefit of colonoscopy is preventing a colorectal cancer that, if it develops from a polyp, typically requires 5 to 10 years to become clinically significant. If you are 79 years old with no prior polyps and an otherwise average life expectancy, the probability that a colonoscopy today will alter your mortality from colon cancer is genuinely small. Meanwhile, the risks of colonoscopy are not theoretical and they escalate with age in ways that deserve serious attention. The bowel preparation, the high-volume osmotic laxative regimen that must be completed the night before, can induce significant dehydration and electrolyte disturbance in older adults, sometimes requiring hospitalization. The sedation required for the procedure carries elevated risk of respiratory depression, prolonged confusion, and cardiovascular stress in older patients with multiple comorbidities. And then there is perforation, a tear in the colon wall created by the advancing colonoscope. The colon wall thins with age, and the risk of perforation roughly doubles or triples after age 75. A colonic perforation is a surgical emergency. Managing it typically requires urgent laparotomy and in a significant percentage of cases results in a temporary or permanent colostomy. For an 80-year-old recovering from that kind of emergency surgery can permanently compromise independence and quality of life. When you weigh the statistical probability of meaningful cancer prevention against the accumulated procedural risks, most major clinical guidelines, including those from the American Cancer Society and the U.S. Preventive Services Task Force, recommend discontinuing routine colorectal screening somewhere in the range of age 75 to 85. Individualized based on overall health status and patient preference. This is not abandonment, this is precision. And there are meaningful, active, zero-risk ways to protect your colon health at every age. The first is symptom vigilance. New persistent changes in bowel habits, blood visible in the stool, unexplained abdominal pain, unintentional weight loss, or a new diagnosis of iron deficiency anemia. These are clinical signals that require evaluation at any age. Symptoms like these are not something to monitor from a distance. They warrant investigation. The second is diet, and I cannot say this emphatically enough. Dietary fiber is the most underutilized colon protective intervention in medicine. Soluble and insoluble fiber from legumes, cruciferous vegetables, whole grains, and fruit feeds the communities of beneficial bacteria in the gut microbiome. Those bacteria produce short-chain fatty acids, particularly butyrate, that directly nourish the intestinal lining and suppress the inflammatory pathways associated with colorectal cancer development. Adding a daily serving of lentils, increasing broccoli and leafy greens, choosing whole grain bread over refined flour. These interventions carry zero procedural risk and confer benefits that extend to your cardiovascular system, your metabolic health, and your cognitive function simultaneously. The colonoscopy window is real and important. Use it during the years when the benefit clearly outweighs the risk. After 75, shift your strategy to smart, active surveillance. Watch your symptoms, nourish your gut, and have an honest conversation with your physician about your individual risk profile. So let's look at what we've covered today, because the pattern running through all four of these tests is the same. whole body scans that transform internal variations that would never harm you into months of anxiety and procedural cascade. Brain MR is for normal age-related forgetfulness that assign alarming medical labels to findings that simply reflect the passage of time. Routine treadmill stress tests that pull healthy, active people into an invasive cardiology pipeline on the basis of age rather than symptoms. And screening colonoscopies continued beyond the age where the risk-benefit calculation stops working in the patient's favor. In every one of these cases, the common thread is this: we are treating the test result rather than the person. We are optimizing for numbers on a report rather than for the experience of a life. What I've learned across more than 2 decades of clinical practice is that health, real health, the health that matters, is not measured in the cleanliness of a scan. It's measured in function. It's measured in your ability to walk to the end of your street, to lift your grandchildren, to read the books you've been saving, to travel to the places you've always wanted to see. It's measured in how much of your time is spent living rather than waiting in medical offices. The goal at 65 or 70 or 80 is not simply more years. It is more life inside those years. And sometimes the most powerful thing a physician can offer a patient is the clarity to say, you don't need that test. You're doing well. Go home and keep doing what you're doing. I want to leave you with a practical checklist. 5 things you can do right now to become a smarter, more protected patient. 1. Before agreeing to any screening test, ask your physician one specific question. If this test finds something, what is the next step and what are the risks of that step? Understanding the cascade before it begins is the most powerful protection you have. 2. Request a complete medication review at your next appointment. Ask specifically whether any of your current medications could be contributing to symptoms like fatigue, memory fog, or balance problems. Polypharmacy is one of the most underdiagnosed sources of harm in older adults. 3. Assess your own functional health honestly. Stair climbing capacity, balance, grip strength, and walking speed are among the most validated predictors of longevity in people over 60. Track these, work on them, and share them with your doctor. 4. Prioritize dietary fiber. Aim for 25 to 35 grams per day from whole food sources. This single change has documented benefits for colorectal health, cardiovascular risk, glucose regulation, and cognitive function. 5. If you're over 75 and a routine screening colonoscopy is being recommended, ask your physician specifically about your personal risk profile and whether the risk-benefit calculation still supports the procedure given your health status and life expectancy. That is not a question you need to be afraid to ask. It is exactly the right question. A medical disclaimer, because it matters. Everything I've shared today is general medical information based on published evidence and clinical experience. It is not a substitute for individualized medical advice from a physician who knows your complete health history. Please bring these questions to your own doctor. Advocate for yourself. Ask hard questions. You have every right to do that. And to this community, I want to hear from you. Have you ever been pushed toward a test that, in retrospect, didn't seem necessary? Have you experienced the cascade I described, where one test led to another, and you ended up somewhere you didn't expect? Leave your experience in the comments. I read every single one, and your stories genuinely shape the conversation I bring to this channel. If this video gave you something useful, a question to ask, a conversation to have with your doctor, a different way of thinking about your health, share it with someone who might need to hear it. That's how we build a community of people who are informed, empowered, and not afraid to ask the questions that medicine sometimes forgets to ask itself. I am Dr. Ming Chen. Thank you for being here. Take excellent care of yourselves, and remember, sometimes the most courageous and the most medically sound thing you can do is nothing at all.